Hi, I'm Jocelyn. Welcome to this audiovisual presentation on application of breastfeeding self-efficacy theory. This theory is the work of Dr. Cindy Lee Dennis, a professor of nursing at the University of Toronto, an advisor to the Provincial Council for Maternal Child Health, Public Health Ontario, and others. She developed breastfeeding self-efficacy theory and the breastfeeding self-efficacy scale. Breastfeeding self-efficacy theory is the theoretical perspective that breastfeeding confidence relates to future breastfeeding behavior. Self-efficacy is a cognitive process of evaluating and forming beliefs about ability, and it predicts health-related behaviors and outcomes. Remember, we're talking about beliefs rather than actual ability. Sources of information that lead to confidence are, first of all, performance accomplishments, success at actual breastfeeding or breastfeeding skills, vicarious experiences, the stories of other breastfeeding journeys and outcomes. These are especially important for those who have no breastfeeding experience of their own yet. Verbal persuasion refers to appraisal by others, and this is where healthcare providers have a really important role to affirm what is going well during a feed. Physiologic and affective states affect how breastfeeding is going, and more importantly, the woman's interpretation of how it is going. A person with 8 out of 10 pain may not feel confident in their ability to breastfeed, no matter how perfect their latch. Higher self-efficacy affects outcomes in 4 ways. First of all, self-efficacy mothers make different choices, starting with the choice to breastfeed at all. Development of attainable goals predicts breastfeeding. Learning to breastfeed requires significant perseverance, motivation, and support. Self-efficacy leads to engagement and an ability to endure setbacks and difficulties. Performance-enhancing thought patterns, like envisioning success, are more common among self-efficacy people, as opposed to thought patterns focusing on perceived deficiencies. Emotional responses. Imagine a severe nipple injury. If a person does not have confidence in her ability to breastfeed as a final outcome, it will feel overwhelming to attempt to latch with that damaged nipple. High self-efficacy supports an analytical response to difficulties and empowerment to face challenges. Let's go through a scenario from real-life practice. We have a second-time mom at near-term gestation, vacuum delivery, and perineal injury. This baby is at risk for hypoglycemia, and we have low blood sugars treated with dextrose breastfeeding supplement. We enter this scenario at 8 hours postpartum, and we have a baby who won't latch. Managing this feeding plan from a lactation perspective isn't actually the point of this video. I've outlined some suggestions I might discuss with this mother, but what we're really interested in is how can breastfeeding self-efficacy theory inform how we address this? Imagine if I could meet Dr. Dennis for my coffee break and ask her, how does breastfeeding self-efficacy theory speak to this scenario? Performance accomplishments. This mom has already had some successes in the delivery room and at the next 2 feeds. Her previous breastfeeding experience is speaking here too, for good or bad. We can highlight for her that 4 months is not only 4 months. She accomplished 4 months of human milk for her first baby, not failed to breastfeed for longer. When it comes to vicarious experiences, we don't know what other stories she has heard about breastfeeding, but we could specifically ask, what do you know about breastfeeding a preterm baby? Verbal persuasion, appraisal by others. We can say, you are doing a great job. Navigating low blood sugars is hard. I'm glad your baby does not require care in the nursery. We can frame the situation as a challenging task that she is succeeding at, rather than suggesting that breastfeeding is easy. This baby isn't latching and is at risk, but we can frame it in a way that builds breastfeeding confidence instead of tearing it down. This mom has a 4th-degree tear. We might be able to improve how she feels about breastfeeding with ice, positioning, pericare, and medication. This baby will likely continue to need medically indicated supplementation and possibly even NICU care. This mother's choices, effort, thought patterns, and emotions will be heavily impacted by whether she believes she's able to reach her goal of exclusive breastfeeding. If I could ask Dr. Dennis some more questions, I might ask, how do we apply this when self-efficacy and performance are inversely related? How can breastfeeding self-efficacy theory help us avoid coercion when our care plan goals don't match the desires of the patient? In conclusion, why are we doing this? Sure, we want to hit those breastfeeding targets, but more importantly, the majority of mothers are planning, intending, hoping to breastfeed. We want to empower them to meet their own goals, even in the face of challenges.